We are now at the second part of the lecture on the basic concepts of evidence-based medicine. Again, I'm Dr. Cherry Bernardo-Lazaro. In the first part of the lecture, we stopped at the step on asking a research question. Now we move to the next step. After asking the question, you now acquire the evidence to answer that question. So you search the literature and online databases for applicable research data. While some of you may still be reliant on most of the common search engines, by now we know that we can look into PubMed for having a good bank of biomedical articles from Medline and Life Sciences Journal. Here are other selected tools for finding evidence in evidence-based medicine. Note that some of these search engines are free, while some would require subscription. After acquiring the evidence, you must now appraise the evidence. When we appraise the evidence, we assess for completeness and quality of the evidence gathered with regard to its validity and relevance. Thus, we carefully examine and judge the literature and identify which studies are biased and which are valid. I know that some of you may be intimidated when it comes to critical appraisal. Allow me to make some few important points to simplify things. What is that? There are usually four components of appraisal tools, and those are relevance, validity, results, and applicability. Remember it with the acronym RVRA. Relevance would ask if the study question is similar to your own. Validity would ask if the study used valid methods to address the research question. And this is usually the bulk of the appraisal tools. But a good knowledge on the basics of the study design would really help. Then you have the results. Know what results you will look for depending on the study design and the question that you ask. So, for example, you're asking about diagnostic. What results will you be looking for? If your question is therapeutic, what results are you looking for? And finally, applicability would ask if the relevant, valid, and important results applicable to your patient. Each of these components have questions or series of questions, which may be answerable by yes, no, or unclear or cannot tell. Although this is not the focus of the discussion, allow me to simplify some critical appraisal tools for you. So I call this CRAP, or critical appraisal. That is, in a nutshell. For diagnostic studies, you have to note that the diagnostic test should be evaluated in a representative spectrum of patients, from those with mild, moderate, or severe cases. The reference standard should be applied regardless of the index test results, and there should be an independent and blind comparison between the index test and an appropriate reference or the gold standard for diagnosis. The results section should give you values that will allow you to plot the 2x2 table and make computations for specificity and sensitivity. Thus, I hope you take time to memorize the computations regardless of whether you are given a 2x2 table, a wrongly placed 2x2 table, or simply just the true positives, false negative, true negative, false negative results. Because you don't know what will come out in the exam. Will they give a correct 2x2 table? Will they give a inverted 2x2 table? Or just give you figures or numbers? You see that the values on sensitivity and specificity allow you to compute for the likelihood ratios, which you will plot in the nomogram alongside with the pretest probability. So I hope you know how to do it. Again, these are some of the things you have to remember in critical appraisal of a diagnostic study. For randomized controlled trials, you should note that the assignment of patients should be randomized, thus the name randomized controlled trial. Aside from allocated treatment, both treatment and control arms should be treated equally. All patients who enter the trial should be accounted for at the end of the study, so we look at either follow-ups or intention to treat analysis. And finally, measures should be objective and patients and clinicians are kept blind about what intervention was received. Medyo mahaba ba? One way to remember the treatment validity guides is through the acronym RAMBO. R, randomization should be done. There should be A, allocation of intervention, and another A, analysis were maintained to groups they were assigned. And MBO stands for M, measurements should be B, blind, and O, objective. There you go for John Rambo. Do you remember him? So easy, right? Going back to the critical appraisal of treatment article, results should allow you computations for measures of treatment benefits such as relative risk, absolute risk reduction, relative risk reduction, and number needed to treat. Remember, the risk is the failure or non-treatment or those who failed in the treatment or failed in the control arm. Most of the studies would report the success. So remember that you have to compute in the context of the risk. So again, in doing your CRAP, your critical appraisal for treatment, remember Rambo for validity and the relative risk computations for the results. Now, when there have been a lot of RCTs or other studies done about a specific intervention or exposure, you'll find more of meta-analysis or systematic reviews. These are studies of studies. In doing it, it is important that relevant and important studies should not be missed. There should be an appropriate inclusion criteria for the studies, and included studies should be sufficiently valid. The results of a meta-analysis should give you a graph known as the forest plot, and studies in the forest plot should ideally be homogeneous, meaning the p-value is greater than 0.05. And if you want to eyeball it, most of the study should land in one straight line from the diamond at the bottom. Again, there you go with the critical appraisal of meta-analysis. Finally, for appraisal of a CPG or a clinical practice guideline, we usually use the AGREE instrument. The components are still aligned with the usual components of relevance, validity, results, and applicability. But you also add stakeholders' involvement and editorial independence. So remember this, CPG critical appraisal has 6 components instead of 4. So aside from the RVRA, you add the stakeholder involvement and the editorial independence. After appraisal, you now apply the evidence. In applying the evidence, you go back to the patient and together you decide whether you will apply the evidence or not. Remember that in the practice of evidence-based medicine, you just not consider the evidence in your clinician's judgment, but more importantly, the patient's preferences and values. Then, after applying the evidence, you ask the patient to follow up so that you can assess whether the intervention worked or not. In assessing the results of the application of the evidence can lead you to another cycle of practicing evidence-based medicine. In summary, we just defined the practice of evidence-based medicine, that it looks at not just the current best evidence, but also the physician's clinical expertise and patient's values and expectations. Furthermore, the practice of evidence-based medicine consists of the steps of assessing the patient, asking the question, acquiring the evidence, appraising the evidence, and applying the evidence, then assessing again whether the evidence works with the patient or not. Then the cycle goes on. I hope we were able to fulfill the learning outcomes of this session. Again, I'm Dr. Sherry Bernardo-Lazaro. Thank you for listening.